welcome to everyone for this Pan-Africa Medical Marathon. I am Trishna, the assigned moderator from Clirnet, and it is my pleasure to extend a heartfelt welcome to all the delegates joining us from across the country as well as from the distant parts of Africa. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, Clirnet. It proudly stands as one of the largest live digital continuing medical education platforms in India, providing a space for doctors to create and share medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Amitabh Banerjee, sir, holding the degrees of MBBS, MD, postdoctoral epidemiology, medicine majoring in community, government medical college, Jabalpur. He is the professor and head community medicine at Dr. D.Y. Patel Medical College, Pune. And the topic of today's session is plague. So here's a brief introduction before we start with the session. The bacterium responsible for the plague, which is Yersinia pestis, has profoundly impacted human history and emerged as a destructive disease. Transmission from one host to other relies on infected flea bites, which can cause enlarged lymph nodes called buboes, followed by septicemic dissemination of the pathogen. Droplet inhalation after close contact with infected mammals can also result in primary pneumonic plague. Individuals residing in areas with a high prevalence of plague can take several steps to reduce their risk of infection, like reduction of rodent habitat, wearing gloves while handling animals. Repellents can also be used as a preventive measure. Outbreaks of the plague have affected populations across the continent, including African communities, influencing both health and social structures. So, without any further delay, I would like to hand over the session to Dr. Amitabh Banerjee, sir. Kindly proceed with your talk. Over to you.
Thank you, Krishna, and thank you for not only introducing me, also about the plague. You have given a good overview. And greetings to my African colleagues and other colleagues all over the world. I am talking about plague today. Usually in practice, we do not see much until unless you are in endemic area. Even then, rarely plague comes. So what happens when you don't see a thing frequently? Suddenly it pops up. You can lose the control. Like you are driving in a road which has no traffic, you are driving very fast, and suddenly something comes up, you may lose control. Whereas in a crowded road, you are careful. So same thing happens for doctors who are not seeing cases very frequently. A deliberate attempt has to be made to be aware of the possibility of a rare occurrence coming up, and also aware about the treatment which is available. This actually happened in India in 1994. There was suddenly outbreak of plague in port city of Gujarat, Surat, and there was a panic among the medical fraternity also. So this is a public urban interface, a study of pneumonic plague in Surat. It is published. An article on this has been published in Indian Journal of Medical Ethics, and there was a panic because plague has caused devastations in the past. Historically, plague has wiped away many continents, large populations, and then definitely there was no treatment before the in the pre-antibiotic era. So, and subsequently, for long periods of time, it is lies dormant, and it when it flared up in Surat, the situations was very poor, garbage disposal, poor hygiene sanitation. There was flood. All these factors led to the outbreak of plague, and plague is something which is always there in nature. It is disease which is basically a zoonosis from animals, and the normal reservoir are the rodents, wild rodents, domestic rodents, wild rodents, peridomestic rodents, domestic rodents, different. And From rodents to rodents, the transmission normal cycle is through the rat flea, Xenopsira cheopis. So this rat flea and rodents are the normal cycle, and the humans are accidental, they get infected. When the rats die, the flea can jump onto the human host. And when the plague enzootic or epizootic among rodents, the first sign of are rats dying, rats falling. So that time the fleas leave the rodents and they can transmit the bacillus, plague bacillus to humans. And there was panic in Surat when many doctors, one-fourth of the doctors, did not know that there is a treatment of plague. And this is in 1994, 1996, when the antibiotics were very much there. In the pre-antibiotic era, there was definitely no, but the mind, the panic is still among the people. So it is again, it is not can't exactly blame because the panic created and because they don't had not seen cases of plague for a long time, and good treatment and management depends upon the knowledge about the disease, and also the knowledge can avoid the panic among doctors. So, and particularly this is relevant for our African colleagues, because in the African continent there are certain parts of the African continent which is endemic among the plague and among the rodents, enzootic. So history, these would be our points: history, microbiology, epidemiology, natural cycle, transmission to humans, pathogenesis, clinical manifestation, lab findings, treatment, and prevention. Historically, it has caused major pandemics over the past 1500 years, particularly in the pre-antibiotic era. First pandemic, Byzantine Empire during the 6th century, killing an estimated millions of people in the Mediterranean basin. Second pandemic began in Central Asia and spread west across caravan routes to reach the Crimean seaport of Kafka, now Ukraine, Fedosia in Ukraine. Third pandemic, modern pandemic began in China's Yunnan province in 1850s. Usually the infection spreads through trade routes, the shipping routes, because the rodents, the ships, they carry grains, food items, and the rodents are attracted to the ship, and the rat flea may be there. So, and you may be aware that the word quarantine and fatigue, they came because of this plague pandemics in the historically. Whenever there was a case of plague or the ship was not granted pratik. Pratik means giving permission to the ship to reach the port, and they had to wait for 40 days. That was the largest, perhaps, incubation period they thought. So that 40 days, the quarantine word actually originated from this practice of pratik and making the ship stay away from the port. Causative agent is Yersinia pestis, and aerobic, it's a gram-negative coccobacillus. Exhibits bipolar staining with Giemsa right and Wason stains. Member of Enterobacteria and grows well on blood and McConkey agar. Epidemiology is important because if you know the epidemiology as a clinician, as a practitioner, you know you will not be taken by surprise. And if you know the epidemiology, you can ask the history of the from the person who is having, say, any enlarged lymph nodes or buboes, or about his travel history firstly. Then particularly plague is also found in Western USA also, those who go for camping in the wild. So they also every year there are reported cases of plague from USA also. It's not that it is something which is only for the developing countries, or so even in developed countries, it is due to adventure or in the wildlife. the contact of humans with the wildlife, rodents and rat flea. So, although not the scouts it once was, plague remains a threat in Africa, Asia, the Americas, including Western United States. Because of the antibiotic, perhaps it gets cleared without sometimes. In 2017, an outbreak of pneumonic plague reported in the capital Madagascar with more than 2,700 suspect cases identified. Madagascar is highly endemic for plague. In the United States, plague have been reported since 1900, initially restricted to port cities, wherever the shipping. Plague is currently endemic in 17 contiguous western, extending from the Pacific coast to the Great Plains. Since 2000, more than 95% of 22,000 human cases from sub-Sahara Africa and island of Madagascar. So since the past 20 years or so, almost 20,000 cases, human cases have been from the sub-Sahara Africa and island of Madagascar. So that is the hotbed of the endemicity, or exotic, I would call it, because basically the reservoir is the animal kingdom, rodents and small animals, or rodents particularly, and from the wild rodents to the peridomestic and peridomestic to domestic rodents, sometimes domestic animals also, cats, dogs, and other animals also. So this is the map of the plague. So if you see the sub-Saharan African countries, and Madagascar is almost covered, Madagascar, even Latin America, USA. So these are the cases, more than 1,000 reported cases in recent World Health to the WHO. And of course, it is scattered. India, it is not showing, but India also, as I said, there was an outbreak in Surat in 1994. Then Himachal in around 2000 in the hills of Himachal Pradesh, there were cases of, I think, few cases of pneumonic plague. So it does sporadically, it does crop up in India also. It is not showing here, but it has been occurring once in a while. And there are sometimes natural disasters can precipitate plague. So we should know, like these are the hotbeds, or these are the reservoirs. These are the reservoirs. So any floods, or particularly sometimes there are earthquakes, like they say in Latur earthquake, the rats, because rats, they are mostly, sometimes they go into estivation, into the burrows. And if there are disturbance like earthquakes or floods and all that, they are out of the burrow, some die, and the rat flea can, looking for a new host, it may find a human host. So these natural disasters can precipitate plague wherever these foci are there. So as a clinician, if you have some general knowledge, you should not be surprised. And this is the purpose. So different natural cycle, as we have already discussed adequately by now. So basically, it is the bubonic plague is more common, which is by the rat flea, and the lymph nodes can be involved, swelling of lymph nodes, suppuration, and sometimes from there it can spread, and that is a septicemic plague, that which is more serious. And rarely from this it can become pneumonic in the lungs, and from person to person transmission of pneumonic plague can occur. And pneumonic plague is very fatal, almost 100% fatality rate if not treated within 24 hours with antibiotics. And even with treatment, the mortality of pneumonic plague is high. So this is the, as I said, these are the, and this is the rat flea, these are the rodents. This cycle goes on in the wildlife, and epizootic can occur. And then if the rats die, rabbits can also be infected, cats, dogs. And if the natural host dies, it can jump to the, flea can jump to the human host. each with their own ecology and predilection for disease. Perhaps triggered by climatic conditions, epizootics characterized by explosive spread and sudden mass mortality among susceptible rodents. So earliest sign may be sudden high fertility among the rodents. So this that is how humans get infected through flea bites, common during epizootics when large number of rodents die and fleas seek alternative sources for a blood meal. Direct contact with tissues or secretions of infected animals associated with increased risk of death and septicemia. In hunters, while handling or skinning carcasses of infected animals, rodents, rabbits, as I said, wildlife, many people go to the forest for hunting and adventure, rarely through inhalation of infectious aerosols. This can be very dangerous because it can really start to pneumonic plague. Domestic pets are also an important source of potential exposure. So these are the three main types, bubonic, pneumonic, and septicemic. Bubonic has a infection fatality rate, a case fatality rate of, even after treatment, it has a fatality rate of 1% to 15%. So it has to be taken seriously. Septicemic has got a higher fatality, almost 20 to 40%, and pneumonic, as I said, is 100% fatality. If treatment is delayed even for 24 hours. So high degree of suspicion has to be there. There is little time, and it can spread from person to person. Bubonic plague results from cutaneous exposure characterized by incubation period of 2 to 7 days, sudden onset of high fever, chills, weakness, headache, bubo swelling of regional lymph nodes becomes apparent in the groin, axilla, or neck within first few days. Bubos vary from 1 to 10 centimeter and elevate overlying skin, which is warm and erythematous. Palpation elicits extreme tenderness. Careful examination distal to bubo reveals small papule or scab. That is the place of the flea bite. Case fatality is 1 to 15% with treatment, bubonic plague, and 40 to 60% without treatment. So we require a quick treatment. Septicemic plague is, again, incubation period is 2 to 7 days, sudden onset of high fever. It is widespread. The bacillus spreads to all organs, rapidly progressive, leading to overwhelming sepsis and organ failure. Some patients show GI symptoms, nausea, vomiting, diarrhea, or abdominal pain. Mortality is 40% in treated and 100% in untreated, almost like pneumonic plague. So there is no time to lose. So your high index of suspicion only can come with the knowledge of epidemiology. So here is the domain, here is the interface of clinical medicine and public health and epidemiology. Your public health knowledge, epidemiology knowledge can guide your clinical practice. So this compartmentalization should not be there. So one has to have an overview of across disciplines. Pneumonic plague occurs in two forms, primary and secondary. Primary, as I said, directly inhalations, aerosols from other patient of pneumonic plague. And secondary is like untreated pneumonic plague, untreated septicemic plague may also affect the lungs and then convert into pneumonic plague. And that person can be a index case for human to human transmission. And of course, high fatality. Incubation period is again very short in pneumonic plague. In septicemic and bubonic, we saw 2 to 7 days. Here you have got no time. Secondary, more common form, arises through hematogenous spread bacteria from vivo or other sources characterized by begins an interstitial process with productive curve, tenacious sputum, chest X-ray, alveolar infiltrate, always bilateral, accompanied by pleural effusion, uniformly fatal if not treated within 24 hours. So primary pneumonic plague result from direct inhalation of bacteria, characterized sudden onset of fever, chills, headache, malaise, rapidly advancing tachypnea, dyspnea, hypoxia, chest pain, cough, and hemoptysis. Diagnosis of plague is careful history, thorough physical examination, chest radiograph used to rule out pneumonia, appropriate cultures, blood culture, and BIBO aspirates. Sputum, tracheobronchial washes, swabs of skin lesion, pharyngeal mucosa, CSF. Lab confirmation through isolation of Yersinia pestis on body fluids or tissues or the BIBOs. Can grow on McConkey media. In patients with negative cultures, plague can be confirmed serologically by passive hemagglutination testing for antibodies to Yersinia pestis. Because sometimes the culture may not yield result, but not to wait. Start the antibiotics. Any case, even if you have got suppurative lymph nodes, you have to give antibiotics. So it can cover plague also, particularly for gram negative. For diagnosis in fatal cases, samples of lymph nodes, liver, spleen, lungs, bone marrow, autopsy for culture, and Carrie Blair or similar holding media can be used to transport swabs of tissues for culture. Now, treatment. This is most important because we should simultaneously start the treatment after taking the samples. Drug of choice is streptomycin. Treatment regime is streptomycin 1 gram intramuscular twice a day for 15 days. Other alternatives are gentamicin because it's a gram-negative organism, 5 milligram per kg intramuscular IV OD or 2 milligram per kg loading dose followed by 1.7 milligram per kg intramuscular IV 3 times a day. Alternative choices are tetracycline. Actually, in our time, we used to use tetracycline and doxycycline, same single dose, 100 milligram BD or 200 milligram IV OD, ciprofloxacin and chlorphenicol. These are the other alternatives. So first line is streptomycin, gentamicin, doxycycline, and chlorphenicol, then ciprofloxacin. For children, preferred choice is streptomycin 15 milligram per kg intramuscular BD. Gentamicin different, you have to calibrate the doses according to the child. And there are some side effects also of streptomycin. They can cause ototoxicity and not well. We have to, but you have to give the antibiotic. You can give alternative. If there is any hearing tinnitus develops, you can change over to chlorphenicol or doxycycline. Prevention infection control is suspected cases should be reported to health department. It is a notifiable disease, international also notifiable disease. Patients with uncomplicated infections treated promptly do not present hazard to others. If you treat a patient, that person will not be hazard to others. In any case, bubonic plague is not very transmissible from person to person. Patients with cough, other signs of pneumonia should be placed in isolation because pneumonic plague is very contagious. Environmental control, good sanitation is important. I was started the session with example of Surat. That thing, that hygiene sanitation of that town was deteriorated very badly. There was garbage, there was filth, and the rodents, this garbage, filth, and all this attracts the rodents. And they come nearer and nearer to human dwellings. If you and any outbreak among the rodents from wild to peridomestic to domestic rodents, Rattus norvegicus, rattus, these are the domestic rodents. They can easily spill over to the humans. So best prevention is the garbage disposal, proper sanitation. And once this incidents occurred in Surat in 1995 or 6, there was a commissioner who came to Surat, I think Mr. Rao, and he transformed the city. It became one of the cleanest city in the state. So it requires administrative action beyond health and medicine. So the filth and the hygiene sanitation, the strong administrator can make it clean, and he made it clean. Surat became one of the cleanest cities after this. Rat-proof dwellings, removing food harbors for rodents. Overall, these are all related to sanitation. Repellents. Repellents is, of course, for humans, this flea bites. Applying insecticides on their pets. Rodenticides. Killing of rats should not be done before the killing of the rat flea. If you want to kill the rat, thinking that rat is spreading the plague, if you use rat poisons, rodenticides, the rats will die and the rat flea will leave the rats and jump to the humans. You will precipitate a human plague. So first you have to spray the insecticides. All the dwellings should be residual insecticides which will kill the flea, maybe on the rats also. And then after you have eliminated, well covered with the insecticides against the rat flea, then only one should go for rodent rat poison. So blindly we should not in haste go for killing the rats, because you see it's easier to kill the rats, but you have to first enforce the insecticides spray. Vaccines are there, but they are not freely available and not generally recommended. We don't know the efficacy. Historically, two types of plague vaccine have been available for humans since 1897. I think Hafkin Institute had produced some vaccines, killed whole cell vaccine and live attenuated vaccine, not effective against respiratory exposures and no usefulness combating epidemic disease. You see, uh, vaccine works in the lungs are direct window to the air, and it is very short incubation period. The vaccine will not prevent against the actually fatal, the pneumonic plague. And for the bubonic plague, you have got enough window of opportunity to start the antibiotics. And with antibiotics, fatality in bubonic plague is 1 to 15%. So I don't think a vaccine has got that much efficacy beyond that. And of course, neither vaccine is currently licensed for use. And I don't know, something is available in Russia. Live wholesale is reportedly available in Russia. We don't know. So this is to sum up, this is the summary. The certain questions. Question one, they are question two, and this is the second question. Question one, question two, and question three. Let us see how it goes. Does rapid diagnosis accurately detect the disease? Because as I said, the actual confirmatory is the culture of Yersinia pestis. And sometimes it takes effort and sometimes it misses. So there are some rapid diagnostic tests that accurately detect the disease. But since the treatment is so effective, if started early after sending the samples, whether it is rapid or whether for culture, one should immediately start the antibiotics. Because after all, bubonic and all, you have to give antibiotics. You start streptomycin, start doxycycline. And and then, of course, some cases, epidemiologically also you link up whether the rodents are dying, and you can collect samples from rodents also. And a good liaison with the veterinary scientist also can help. Then how effective and safe are the antibiotics for treating people with plague? Question two. Because as I said, some of them like streptomycin has got ototoxicity, and then how effective they are. There are no randomized controlled trials, and I was reading somewhere because this is one of the neglected tropical diseases. So if you see, even with treatment, fatality is 1 to 15%. And for the most milder forms of plague, that is the bubonic plague, with treatment 1 to 15% is very high. and pneumonic is 100% if your treatment is delayed 24. So there, I mean, it's quite a neglected disease. And you see, question three: which routes and for how long a human remains contagious? Mostly, human-to-human transmission of bubonic plague is not common, but of course, body fluids and all, we don't know. So there may be other routes also, by say parental transmission or sexual transmission, but it's not well. So these are some question marks. Exposure to the remains of people who died of plague. Exposure to the remains of people who died of plague, because that fear is there, no body died of plague, so do they transmit? So anyway, if you can uh, have a proper cover the body, don't handle the tissues, so probably I think it is safe. And of course, these are cost, cultural acceptance, flea bites, infection of a new case starts with inhalation, handling of infected tissues or fluids, infected domestic cats, flea bites, postmortem exposure. These are the infection, clinical plague, antibiotic treatment. Then antibiotic treatment, how safe it is. Then diagnosis, confirmed case of plague, antibiotic treatment. Suspected plague, as I said, you don't wait for the confirmation. Clinical suspicion, start the antibiotic treatment. So this is the sea tanker of managing plague, antibiotic treatment. So these are the antibiotics: fluoroquinolones, streptomycin, gentamicin, doxycycline, bromfenicol. Then these are the efficacy, compliance, ease of administration, cost, safety, adverse, cure, death, sputum negativity. So this is the diagnostic state accuracy. These are the issues in. So I think this is all we have covered, and these are some of the references I have tried to give if you want to do further reading. SA, this is the Doctors and Plague, that's the Indian plague in Surat, 1996. Then this is the China, 20 years data, more than 20 years data this paper has got from 1950 to 2020, 70 years, epidemiologic statistics of human and animal plague in China. So as I said, the last major year was China. So this paper is a very exhaustive paper which has traced the epidemiology of plague for the past 70 years. And this is a systematic review and clinical profile of patients with bubonic plague. And this is PLOS, neglected tropical disease. As I said, these are the neglected tropical disease and outcome measures in research settings. This is also a very good paper. Then there's some textbooks I have used. So see, Mandel, Douglas, and Bennett's Principles and Practice of Infectious Disease, 9th edition. WHO guidelines are there for plague management. Some of the last sketch I think I had taken from there. So these are the references. I think that's all. I think I can stop sharing the screen. Thank you.
Thank you so much, sir, for the comprehensive talk, and the content was highly informative. So, we have received a few questions from our participating doctors, and with your permission, I will be sharing them now.
Yeah.
Okay, sir.
What are the long-term complications or sequelae of surviving plague infection, and how can healthcare providers support recovery and rehabilitation? The most severe long-term complications, I suppose, would be a person who recovers from pneumonic plague, because they would maybe extensive lung damage, because it can be quite aggressive on the lungs. So it would require pulmonary rehabilitation, and it will require support of the pulmonary physiotherapist and others. Pneumonic plague after the bubonic plague and all. I don't think there would be much long-term complications. Of course, for septicemic plague, if they are organ damage, so it depends which organ is affected, whether it is a kidney or liver or what. So these are depending on the there can be number of long-term complications. So yes, it has to be fully assessment has to be done after recovery, and depending on the assessment, it has to be tailor-made, customized for each patient. Yes, this is also very important because as we saw the even in bubonic plague, the treatment failure is ranging from 1 to 15%. I mean, 15% is very high for a bubonic plague. That means there may be antibiotic resistance. And there is at present, it is, as I said, one of the neglected tropical diseases, and we don't see it in daily practice. So, not much research has been done to monitor and combat resistance or to find the ideal combination, antibiotic combination. So whatever drugs are being used, they are used since ages, starting with streptomycin, tetracyclines, chlorphenicol. So these are, yes, I agree. There are certain gaps. As we saw in the questions also, last three questions, when it was summed up, this was the one of the questions key. What are the efficacy and effectiveness of antibiotic therapy? So I agree. This question remains. So yeah, I have the same. I've been this initiative by Clirnet to reach out transcontinent is a very good initiative because we get enriched and we get world is becoming very connected, very connected. If play and because of the frequent travel and movement, so one from one part of the world to the other part of the world, disease or any outbreak, say, be it plague or be it any other, it can spread also. And history, so I would like our African colleagues also to keep a open eye and a high index of suspicion. They should share their experience and knowledge as they gather on this disease plague, which is particularly relevant because in Africa, because as we saw the map, it is endemic in Africa and particularly Madagascar. So definitely, perhaps I feel that we have more to learn from our African colleagues on plague than we can give them information. Thank you so much.
Thank you so much, sir, for addressing all the inquiries from our participating doctors. I also extend my gratitude to all the participating doctors for their consistent engagement on our platform. And once again, thank you for generously contributing your valuable time and efforts in this session today. So, lastly, before ending the session, I would request you all to follow us on our Facebook, Twitter, LinkedIn, and Instagram pages to stay updated on the latest medical info. So